Good morning and welcome to Southern Maine Healthcare's Medically Speaking. I'm your host, Robert Erickson, and for the next 30 minutes, you'll hear about medical issues and topics of the day directly from leading medical professionals at Southern Maine Healthcare. Welcome to Medically Speaking. Opioid addiction is the public health crisis of our time. In Maine and New Hampshire, more than one person a day dies as a result of an overdose. It is a remarkable statistic that touches many, many lives. Today on Medically Speaking, we have a special guest, Dr. Jessica Morin, a family medicine provider at Southern Maine Healthcare and a member of the Maine Health Opioid Implementation Steering Committee, which was formed in 2016 to address the crisis in our region. Welcome, Dr. Morin.
Thank you, Robert, for having me on the show today. I really appreciate it.
How did we get here? Why is America so addicted to opioids?
So that's a very good question. When we look back into the 80s and even in the early 90s, we as a medical community struggled to treat pain. When the pharmaceutical companies came up with oxycodone, or OxyContin as it's better known, it was touted as something that could be almost like a magic bullet for pain. The companies also reported that the addiction potential was low, which was not the case. Additionally, there was pressure to do what's called the fifth vital sign, which is to assess pain, and the American Society of Pain wanted that to be a part of an initial intake with patients in hospitals, and that bled over to clinic visits as well. So when you have physicians or providers that have to focus on pain, and you have a medication like OxyContin that purportedly had a low abuse and addiction potential, you can kind of see where that might become an issue as far as overprescribing. I think what then began to happen, what I noticed when I was in private practice as a family physician, is we were ill-equipped to deal with individuals that needed escalating doses of pain medication to manage their pain. And then once they started to exhibit signs of addiction, the resources in the various communities just were lacking. So individuals weren't able to get the help that they really needed. What we saw was a trend of, and I use this very loosely, but abandonment in the sense that you have physicians and providers that are ill-equipped, don't know what to do, seeing escalating doses for these patients and saying, I'm not going to fill those anymore. And it left these individuals going through withdrawal and resorting to illicit substances to maintain both control of their pain and a sense of normalcy so that they weren't going through withdrawals. So it became this vicious cycle at that point. But that's what I see as a critical turning point, is both with pharma and that OxyContin hitting the market, and then, of course, the American Pain Association or Society that wanted us to be doing the fifth vital sign, which is that pain assessment, that 0 through 10 scale, which we still use, but it's just now less important. It's a tool, but I think we really were so focused on pain before that we kind of lost sight of what's medically safe.
Now, there's a lot of blame being put on the big pharmaceutical companies, of course, and that could be a whole show of its own. But maybe tell us, how did the medical community deal with pain before these new opioids?
So if you kind of look back in medical history and you go back into the 30s and 40s, people were very afraid of pain, as they are now. I mean, people are scared to experience severe pain. And it was actually understood that if you sought pain relief or you knew you were going to do a procedure, that you were going to suffer, because there really weren't necessarily good options. There were options, but I would say that providers were much more stringent about the use, and patients suffered more. And that's why that movement to address pain and be better and more attuned to patients' pain kind of took over in the 80s. So we did use the regular, what we call NSAIDs, the non-steroidal anti-inflammatories, acetaminophen, which is Tylenol, and as I said, the NSAIDs, which would be ibuprofen, Motrin, Advil, Aleve, Naproxen, all those. And we did have we had some other ones, derivatives of heroin and codeine. But again, it was just much stricter. And then what we watched in the 80s is the pendulum swing to being almost too liberal. So I definitely wouldn't blame just the pharmaceuticals. I think it's kind of a perfect storm of the pharmaceutical companies saying this particular medicine won't be as addictive, or the potential is less. And then I think medical societies that were promoting treating pain adequately. There were some state boards that are actually being punitive on physicians if they didn't treat the pain adequately. And so patients, would file complaints if their pain wasn't adequately treated. I can tell you stories about when I was an active physician in the military, in the U.S. Army, and having the head of the hospital come down what we call the red carpet. So you knew if a provider came down on the red carpet, you knew you were in trouble because they're the head honchos. And I refused to fill fentanyl lollipops, MS Contin, and I think Percocet for a 42-year-old soldier who had been medically retired because of Parkinson's and some low back issues. And I felt it was just too much. And, this is in early 2000, and I got in trouble. So the reality was it wasn't, just all the doctors kind of saying, let's be negligent, but there was a whole kind of paradigm shift about how to better address pain without really thinking about the consequences and truly understanding the pharmacokinetics of these drugs and the implications and the impact it's going to have on these individuals. That particular individual, I stayed strong and didn't give it, and that was thankfully honored, but another physician stepped up and did it. And about 6 months later, it was found that he had set up a bunch of different medical centers, and he was hopping to each one. We didn't have back then a PMP of sorts, and so that's a prescription monitoring program. And so that individual is going all up and down the Midwest, and we eventually figured out with the help of law enforcement. So he was addicted, and so it was really sad that in that moment we couldn't help him. That we just kind of came to that pressure of, we need to treat his pain. This is what is been shown to be the right course of action.
So what's the transition from being treated to addiction? I mean, a lot of people get pain medication frequently, especially as they get older. So how do you know if you're addicted, and what is the transition?
Right, that's another excellent question. So it's a little bit complex for the four of us that are in the room. It doesn't mean all of us, if we get hydrocodone, are all going to get addicted. It doesn't take that much time, though, if you have the propensity for it. It can be literally 5 days, and you could potentially start to show some physiologic changes, so which we would call dependency, and then it could escalate to addiction. What I can tell you is individuals that are more at risk for developing addiction tend to have a mental health condition as well. Not always, but tend to, whether that's depression, anxiety, bipolar, just to name a few. That doesn't mean it's a given, but that's one risk factor. Another big risk factor is childhood trauma, that something is displaced. We don't know exactly why, but we do see that association that individuals who have been sexually or physically abused as children, that they do tend to have an increased risk of addiction. You have to understand that with addiction, what typically happens when they take an opioid is they're able to, and I call it numb out. They don't experience the moment. And often when you talk to a person that has opioid use disorder, they talk about unbearable instances or experiences that they have, whether it's anxiety because they can't speak in public or what have you, but they just want to zone out. And that enables them to do that, and it becomes like a coping mechanism. And what you often find with folks that have addiction is they had triggers all along, whether it's seeing, I'm just going to make this up, like their ex-husband on the street and he beat her or what have you, and they freak out when they see him. Maybe before they would cry and run home, but now they have a substance that can numb them to that experience and make them feel like it's okay and that they can move on. Obviously, that's not a healthy choice, but the physiologic changes that occur in the brain make it so that seems like the right course of action. A lot of individuals, once they recognize that they have an addiction, and how people can have some self-reflection on that is they find that their functionality as a whole decreases. So To give you kind of more palpable examples, you take an individual that becomes addicted to opioids, they may lose their job, they may lose their partner or their spouse, they may lose their children, they may lose their car, they may lose their housing, they go into debt. So all these kind of earmarkers of what we would consider a functional individual has started to chip away, and it's the opioids that are chipping that away, or the addiction. And obviously that can be true for methamphetamines, for cocaine, and for alcohols. But with opioids, it truly changes the brain chemistry and messes, for lack of a better description, with the pleasure center of the brain. And it gets to the point that they aren't even really getting much of a high. They're only becoming more normal, or they'll do so much more excessive to get a high that then they run the risk of overdose.
Now, is it fair to say that addiction in our society covers all economic groups, the entire economic strata?
Yes, that's very accurate. Leading to my interest in caring for folks with opioid use disorder, I initially worked at a facility co-located both in Portland and in Lewiston, where we only treated opioid use disorder. There I was prescribing methadone as well as Suboxone. And I definitely saw what I would consider high functioning executives in big companies, and the opposite of that. I think what it's sad, and I'm seeing a transition, but not fully, is the stigma that surrounds this condition, this disease. And for the pretty high functioning executives, there was so much shame, and it broke my heart, because you wouldn't feel that way if you had diabetes or if you had hypertension or Parkinson's, and yet these individuals just wouldn't even let me talk to their primary care doctors. So it was heartbreaking to see that.
Now, in your experience in your practice and just in your general experience, what were the things that caught your attention that really seemed the serious issues regarding opioid abuse?
So I would hearken back to actually when I was in the military, so quite a while ago in the 90s and early 2000s, and having soldiers coming back with pretty significant injuries, missing limbs, having phantom pain, those things, and initially having high doses of narcotics to control pain, and then having the psychological almost attachment to them because of struggling with PTSD. And we had a soldier that overdosed, and it rocked my world, seeing that happen, and having the parents come to the base and having the general come for the whole base, and just realizing we're doing such a disservice to these individuals. So that was the first time I knew something's not right. We're not doing this correctly. And then when I transitioned to being a civilian and practicing privately, seeing sort of the same thing. I was the new kid on the block, so I got all the patients nobody wanted, and I hate to say it that way, but they were chronic pain patients that all the other providers that were well established had fired, and they were mine. And so that was eye-opening, and I remember one young man, I think not even 20 yet, and he was a college student at K-State and at Kansas State University, and he had a back injury, and it really wasn't that big of a deal. It wasn't a fracture, it wasn't a disc herniation. It just, was a bony contusion. And we did everything, sending him to orthopedics, sending them to an equivalent of OMM, so some manipulative medicine and massage, NSAIDs, all the basic stuff. And eventually we did have to do narcotics, and it escalated. And so I finally sat this young man down, and I said, this isn't making sense. You're on these almost, they would kill a horse, the doses that you're getting. This just isn't making sense. And he said, I can't function. And he was very tearful. And I said, look, would you give me permission to talk to your mom? Because I couldn't really get at him. He was so focused on his pain. And so I called his mom, and I said, I'm really worried about your son. I said, I don't know what's going on, but he's having escalating doses and frequent refills. Something's not right. And the mom said, he didn't tell you this, but his dad died of addiction, heroin addiction. And this is early 2000s, so this wasn't as common. And whether this is good or bad, I said to the mom, you need to come here and get your baby and take him home and get him help, because we just didn't have anything in the small as Manhattan, Kansas. I'm sure now it's a lot different, but and she did. She lived right outside of Kansas City, and she got him. And we lost touch after a while, but he was in a program. But that's before even doing any of the addiction true care of opioid use disorder, that I knew we were having huge, huge issues.
You're tuned into Medically Speaking. Today we're talking to Dr. Jessica Morin, and we'll be back with more of our talk right after this brief message from Southern Maine Healthcare.
For high-quality walk-in care, the best team is always on the ball. Look for Southern Maine Healthcare's Orange Walk-in Care Ball. With convenient locations open every day, it's your guarantee of quality walk-in care delivered by your hometown team.
And we're back with Dr. Jessica Morin from Southern Maine Healthcare. Well, these are compelling stories, and obviously in Maine, we have a lot of these issues here. And in October 2017, Maine Health, which is the family of organizations including Southern Maine Healthcare and Maine Med, launched the Integrated Medication Assisted Treatment Program, also known as IMAT. And you're heavily involved in that. What is the IMAT program?
So the IMAT program is basically a type of recovery program. What Southern Maine Healthcare and Maine Behavioral Health have done, and obviously we fall under that umbrella of Maine Health, is we've really partnered together where when patients are seeking medication-assisted treatment, they go first to the hub. So this is when they're in the throes of their addiction, they've acknowledged that there's a problem, and they're seeking help. So they're first seen at our one of the hubs that has been up for quite a while, and I think since the summer of 2017, is located in Biddeford. And there the patients are assessed to figure out, what are the problems. It's usually not just opioids. There's usually other substances of polysubstance abuse that's going on. Not always, but usually there can be co-occurring problems like depression, anxiety. So they kind of tease out what can they help them with. So it isn't just necessarily, you're only IMAT. It can be, but they can do other care from them. And it can even be, they're suffering from opioid use disorder and alcoholism. So it's a great place for patients to start to help them sort out, what's the best treatment plan for them. If they qualify for the IMAT that we have at Maine Behavioral Health, it is with Suboxone only, so it's not methadone, and they undergo basically IOP, which is intensive outpatient care or treatment, and they have certain levels that they need to progress through in their recovery at the hub in order to graduate to a lesser intense level of care. And with Suboxone in particular, you get inducted into it because Suboxone has a ceiling effect. And also, if the patient has any opioids on board and we give them Suboxone, we actually can throw them into very severe withdrawal. So there's a special little art to how you get somebody on it who has been suffering from opioid use disorder and has recently actively used before you see that individual. Once they're inducted, then there's a stabilization phase where we try to figure out what is the best dosage, what makes sense for them. And meanwhile, they're going through intensive clinical behavioral therapy as well. And then once they are on that stabilization phase, they transition to a maintenance phase where they're starting to see improvement in their lives. A lot of individuals, when they're transitioning to the maintenance phase, have secured housing or they've secured their job or both. So things are starting to improve. And once we see that stability and that kind of forward positive momentum, they get transitioned to a spoke. And for Southern Maine Healthcare, we have two spokes, one at Saco Family Medicine and one at Sanford Family Medicine. There's a correlating hub with the Sanford Medicine Group, which is the Springvale hub. But once they go to the spoke, that's basically like they're seeing their doctor. So that's their family doctor. What we're trying to do is have the family doctor that is your family doctor also give you the the Suboxone, but that's a slower process. We have individuals within both clinics that give Suboxone, but that person may or may not be your family doctor as well, but you will have family medicine care there. So it becomes more of a holistic approach to the patients once they're in maintenance phase. We really treat it like it's just another disease, and I think that helps to destigmatize it for the patients, because recovery for everyone is different. You may recover in 18 months, I may take 5 years. So I think when Suboxone first hit the market, it was like, everyone needs to be off by 18 months to 2 years, and that's just not reality. You may lose weight and not need insulin anymore or metformin for your diabetes, but maybe you do. Maybe you're really skinny and you still need it, So everyone's different, and that's the approach that we take that is truly as individualized.
So what kind of success rate are you seeing? And what are the program's been in effect for about a year and a half? What are the results you're seeing?
So that's a really, really good question. And I say that because I know that folks kind of want to see success being off the medicine and away you go. And obviously that's ideal, but we measure success by how the patient is functioning. Have their legal troubles resolved? Are they finally off probation? And sort of what I named before, do they function in their society or their community in a holistic sense? Like they're contributing, they're paying their bills, they're going to their job on time. And we're less focused on, are they off the Suboxone? It's like, my feeling is if you're on Suboxone and you're fully functional every other way, and this is what's making it work for you, and I can't get you off completely, I would rather have you on 2 milligrams a day and fully functional with your kids back in your home than off it and risk a relapse. So there is a shift amongst those that work in this field of not necessarily everyone has to get off. We definitely do, and we talk about it a lot at the visits. You think you're ready to go down, we call it tapering, and that's the goal. I have seen successful tapering in other programs. I worked at another sort of like IMAT thing called Recovery Together, and we did see some success, but I was there longer than I have been with Southern Maine Healthcare. So I'm very optimistic to see those successes, but they're one of many types of successes that we can have.
Now, you had one of your patients, Andy Allen from Falmouth, who went public with his recovery so he could help other people. Maybe you could tell us a little bit about Andy.
Yeah, that's a great case. Andy, he's now being cared for with Dr. Kowash. So he is at the Saco Family Medicine spoke. So I did initially take care of him and then transitioned his care to Dr. Kowash. But Andy came from a very well-off family in Falmouth, Maine, and he had a mom and a dad and siblings. I actually went to school with his older brother, so I knew him. He's a lot younger than I am, but I did know him. And, he was a golfer, and he had some back injuries, nothing significant, but had some back injuries and did seek some help. He was given some narcotics, and he didn't initially get addicted, but he definitely remembers liking it and maybe using it when he didn't need it. But in college, things kind of got out of control for him, and there was a lot of drinking. And then he noticed a problem because he was having legal troubles. I think he got 2 DUIs. So that right there kind of says, we've got a problem here. This isn't just you partying and, falling down at a dance. It's a lot worse than that. So he recognized that. I think he tried to get that under control, and then he was in a relationship, I think at the end of college, kind of afterwards, that was very abusive and has really scarred him emotionally. And he really struggled to cope with that and what that did to him. And I think he looked for ways to check out so that he wouldn't feel so much pain. And he was self-medicating. And a lot of these folks will self-medicate because, maybe they don't have time to go see the doctor or they don't have the money. But that's kind of how he got to where he got. He, thank goodness, did recognize, I mean, this individual is very intelligent. He recognized that I've got to get my stuff together. And he actually started to purchase Suboxone illicitly with the intent of self-medicating for his addiction. And then he heard about the hub work in Biddeford and said, I want to do this right. And I want to have structure, and I want to stop getting exposed to high-risk situations where he'd have to buy on the street, because obviously people that are selling Suboxone are selling other things. So he was able to get started with the program and has done real well. So we've been very impressed.
So do you find that people who are suffering from addiction actually know that they're addicted? If someone's listening to this program, for instance, and they might say, hey, that sounds familiar, are they able to make that kind of judgment about themselves?
I think some are, some aren't. It depends on where they are in their disorder. A lot of folks feel like they can handle it themselves. So they'll say, well, I'm not going to use today because I've got my kids today. Or they say, I'll just take one pill so I don't withdraw and everything will be fine when I go out to dinner with my folks. And they really try to manage it, but they're definitely not naive to the fact that things have fallen apart. I think it was in the paper recently of a gentleman that was a high-functioning nurse and doing really well and kind of slowly went down the tunnel of addiction with opioids. And, he lost his job, he lost his home. It just was devastating for this individual. And he knew on some level, but just like any disease process, you don't have the same control. It isn't a choice. It isn't them saying, oh, I'm just going to stop. It doesn't work that way because the changes have already happened in the brain. And even if you desperately, and a lot of them desperately want to stop, can't. They simply can't because they'll start to go through severe withdrawals. And then there's the emotional crash that happens that now they're going to have to deal with all the pain that they've clouded over with the opioid, assuming, that's whether it's physical or emotional pain.
So family and friends can play a significant role in helping someone recover. Is that correct?
Yes, that's definitely correct. And I think approaching it as a family member, knowing that it is a disease process and that everybody's individual. Some people can do very well and acknowledge that, yes, this is a problem for me and get help, and others will resist. But I think the other key to understand is you're in for the long haul. This doesn't just go away after you start Suboxone or a different, recovery program. That the disease is relapsing and life is hard. I hate to say it, but life is really hard, and you're going to have triggers. People that you love are going to hurt you or leave you or die. And that even a healthy, normal individual who has no problems is going to struggle if they lose a partner or have a significant life event that can be negative.
So how do they get help? You have some contact numbers that people can call?
So what I would recommend is getting in touch with one of our hubs, the one in Biddeford or the one in Springvale. The number is 1-844-292-0111. And that, I'll say it one more time, that 1-844-292-0111. And that they refer to themselves as IMAT, as do we in the spokes when you're in maintenance. So you'll hear IMAT a lot. But that number will kind of get you in the right direction. They'll ask you, which location would be better for you. And even if you're not suffering from opioid addiction, maybe it's cocaine or it's alcoholism, they will help you find the right place to go. If you call at Biddeford, you're probably going to speak to Dora, who is lovely. She's a wonderful person, very caring, and she will definitely help you. And the one in Springville is Carol Oliver, and she's also amazing. And they're open Monday through Friday. We are going to be opening up what I would call a rapid access program. It has not opened yet. We're hoping for late February, early March, where individuals that come to the Biddeford ER or the Sanford ER for Southern Maine Healthcare could actually start and get inducted